OCT, how it's used in different situations, in calcified lesions, bifurcation. So I'm going to just tell you how to use it with the present interface that we have now, and that's the Ultron 2. So obviously, we know that angiogram has its own limitations because it's a 2D structure. So imaging does help, especially in your foreshortening, when it's overlapping, or when you have in bifurcations. Now, the advantage of the new interface is that, as was pointed out, you have artificial intelligence that tells you about calcium, it tells you about EL detection, the landing zones, etc. And now, with your 1A recommendation in acute coronary syndrome and chronic coronary syndrome, it's much more simpler. We have all been speaking about this algorithmic approach to a PCI. So you strategize it first, and then with your MLD, and you optimize it with this MAX, and this is very, very intuitive when you come to this new interface. So let us take a case, a very simple case for you to see how we simplify this. Now, this is a gentleman who had a stent, and now he's come with an ISR. So obviously you can see it, it's an ISR, it's pretty simple, so we do an OCT. Now, this interface tells you the morphology first, before you size and before you deploy and before you review. So let's go step by step on this. Now, when you run this, it will tell you if you have calcium, it tells you the angle and the thickness. Now, obviously, any calcium less than 270 degree, you can just forget about it. You see neointima here, around inside the stent, and based on this that you see, you can take a decision. You don't have much of calcium here, but you have a lot of neointima, and your device selection is based on this morphology. So now you're going to use a cutting balloon, but you want to cut the neointima, so you use the cutting balloon, and you get a decent result. The next part of it obviously is, you're going to stent this, or you're going to put a DCB. Now I want to stent this. Now, how are you going to do the L and D part of it? That is the length and the diameter. So you go to sizing, and it sizes it for you. It tells you what the EL is, as someone said. The EL detection is automatic. So you know in proximal, that's your EL, that's your lumen, and you know distally, that's your EL, that's your lumen. But you don't have to believe that, You can just scroll it, go to your this thing, scroll the proximal marker to decide whether you really want it there or whether you want it in a different position, where you want it distal, where you want it in a different position. Try and get it into a situation where you respect these figures for the landing zone, where you have less of plaque burden, you have a more visible EL, and then of course, size your stent depending on your EL and the lumen, and as has been told number of times, when you have an EL, step down the size, and when you have a lumen, step it up. So once you've done this, we have decided that based on the distal size, we're going to go with the 2.7528 and deploy that and get a decent result. Now you'd say, how did we go through this 2.75? And I go back to that, you had a distal EL that told you it was 2.8. So that's how you stepped down and you went to this 2.75. 28 millimeters, you got on that sizing, it's 28 millimeters. So that's how you size the stent and you deploy the stent. Once this is done, now you come to the optimization part of it, and that is what we said as has been told, expansion, apposition, dissection. The beauty of the interfaces, it tells you in orange that you've got a malposition here. It tells it on the coronary anatomy also, because it's co-registered, but there you have some malposition there. It tells you about expansion here automatically. You're underexpanded here. And it tells you there where the under-expansion is. So based on this, you decide that you are going to optimize it. And obviously, you're going to optimize it. See this malposition over here? I'm just running it because though the machine has told you, you can run it, see it, confirm. This is the expansion parameter that are being told you. So you take 80% expansion or 90% expansion depending on what you want to do, and accordingly go ahead with it. So when you optimize it, again, wherever your under-expanded area is, if you find an EL there, step down on the size, or if you put a lumen there, you step up on the size. So here, we stepped up and went up to a 3 millimeter balloon and tried to optimize it. It's as simple as that. So now you look at the optimization figures over here. You do not have any malapposition, as I showed you earlier, and your expansion, it tells you it's around 90%. So there you have it, on the machine. And you have all your optimization done, review it, you're very happy about it, and you have, get your parameters right, and at the end of it, you compare your pullbacks. This is the first pullback where you had an MLA of 1.12, now you've got an MSA of 4.84. You're happy with that? Expansion's 90, you completed the case in 30 minutes. That's how you simplify a complex procedure with the use of the new Ultron interface. Of course, there's additional things, and I'm just going to run this or show a couple of slides on this. Bifurcation's phenomenal. The 3D tells you very well, malapose struts, different views, and you get to know this unintended stent deformations. Of course, you'll hear a lot more about this. The side branch crossing that Ankush told you about, very clearly, distal here. In this new platform, this is proximal, this is distal. And that's different from the previous platforms. So, this is the proximal strut, now you know you're crossed distally. Here you can see you're crossed proximal. So, that's the advantage in side branch crossing. Calcium detection, as we have already discussed, very good. Tells you the angle, tells you on this 3D where exactly the calcium is, tells you on the artery where the calcium is. So you can define what you're going to do. And as I said, if it's less than 270, don't bother, but if it's more than 270 degrees, you've got to do something and you've got to calcium modify it. And importantly, it confirms calcium modification. Got an IVUS, you see the cracks well, you see orbital, you see the sanding. With a rotablator, you see the bird segment. And as we just said, I think this future will simplify it even more. We are here.